different people define it very differently. We regard population health as any attempt to improve the health of the community, the population, or whatever it might be. In the case of sleep, for instance, communities can be a church, it can be a barbershop, it can be a beauty salon. So long as you're targeting a very specific group, that's a population. The center has many components. Some of us think of it as different units. The unit in which I'm involved is primarily to develop behavioral models to address various conditions such as diabetes, hypertension, and recently we started to look at sleep apnea in particular. So it's a question of developing models that are acceptable to the community, whatever the community might be, in a way that can effectuate positive changes. Most of the work that I'm personally engaged in address to some degree sleep health disparities. Sleep has become, or has always been, a very serious concern for a lot of communities. But recently, because we're talking about this on TV, people hear about it, they begin to ask questions. So when you go to churches, it's amazing how many people come up to me and ask me questions about sleep because they think now it's a problem that has to be addressed. In minority communities, Latino and blacks in particular, sleep apnea is a very serious problem. If you were to compare blacks and whites, the ratio is 3 to 1. We would find that African American men in particular have sleep apnea. Now, sleep apnea is this problem when you go to bed at night and you start breathing sometimes 100, 200, 300 times a night. And this can affect your ability to function during the day. We find that some people fall asleep and they can cause accident because of that. We now realize that people who have Alzheimer's disease, for instance, this may be caused by untreated sleep apnea. So when you treat them, brain function gets to be better. When you treat sleep apnea, increased productivity, less car accident because of they're not as sleepy as they used to be, and quality of life improves. Unfortunately, for minority men and women, Latino or blacks, they're really not accessing health care to get the benefit of sleep apnea. So although sleep apnea is terrible, when you treat sleep apnea, you reduce cardiovascular disease risk by 64%. Now, how do we get those members of the community to actually go to a sleep center and participate and get the kind of care that they deserve? There's a project which we call MEDSO, which focuses primarily on blacks with metabolic syndrome. We find that even if we engage them by providing them behavioral health intervention that is tailored to their needs, yet a lot of people still don't go. We find that through debriefing that they really don't want to go because of past experience. We've had a few instances where patient would tell us, well, you know, the reason I don't want to go is my uncle went to the hospital and he didn't come out. That is, the uncle died. So when you ask them to do a sleep study at a hospital, they're just not going to go. So we now just started a new project which we call PZ, where we have P-health educators talk to their clientele to try and engage them in conversation about why they should get a sleep test done. Not at the hospital, but at home. This is having more success because people feel a little bit more comfortable getting the sleep test done in an environment where they feel, I am in control. The other project, which we call TASH, is about engaging members of the community, churches, barbershop, beauty salons, trying to understand what the barriers are and also come up with a platform that is very scalable. In this case, we're talking about websites as well as text messaging as a way of increasing sleep health literacy. We just started this, so we can't say a whole lot about it. The idea would be, once we find a message that works, that shows efficacy, we want to be able to make this available to all minority men and women, wherever they might be, so that by increasing health literacy, they will be more likely to engage in practices that would improve their sleep, which would then translate into reduced cardiovascular disease. In the context of health equity, which is to try to understand what the barriers might be preventing adequate access to care, we're finding that quite a bit of mistrust or distrust of the healthcare system. So we find that when we engage members of the community, there's a much better chance they will actually participate in healthcare practices. So all of our work is about engaging stakeholders in the community, patients, community providers, to try to come up with ways to help them overcome those barriers. We find that, for instance, in the churches, when the pastors and the priests tell them to go get a screening for diabetes or hypertension, believe it or not, they are more likely to engage in that versus their own primary care physician. So these are very influential members that we are counting on in terms of behavioral health interventions. If I showed up by myself, and which is what we've done years ago, not very receptive. You want to be able to have members of the community that introduce you. So now we understand, before you go to a barbershop and begin to conduct research, you want to blend in. By that I mean, you want to go a few times, just as a client perhaps. You want to go just say hello, how you guys are doing. And after a while, you begin to be one of them. At that point, you can engage them in conversation about diabetes, hypertension, or sleep. So it's a question of how do you do that? How do you engage them? A lot of people don't want to do this kind of work because they find the process to be a bit cumbersome. Some of us at the center, we enjoy this kind of work. I think it's important because ultimately we want to reduce cardiovascular disease risk, which is a significant burden in our populations, in our communities. My focus primarily has been sleep, although I recognize that hypertension, diabetes, other areas we care about at the center. Sleep, in fact, triggers diabetes, triggers hypertension, and of course cardiovascular disease in general. So by targeting sleep, whether it be sleep apnea or reduced sleep, some people just don't sleep enough, not because of sleep apnea, but because they're pursuing the American dream, they're not sleeping enough. You might have heard about this. Short sleep and long sleep are cardiovascular disease risk. Unfortunately, about 20, 40 years ago, we used to sleep about 8 hours. Now we're sleeping at about 6, which is simply not enough. So the message is you gotta have a balanced life. Pursuing the American dream is a fantastic opportunity. I do the same thing too, but also acquiring the amount of sleep you need to increase survival and longevity is crucially important. We find out through focus groups, where we engage people in conversation about what matters to them, the perception of sleep need is very different. In fact, we're working on a book chapter now that addresses this. Our friend Collins from UPenn looks at historically what the perception of sleep has been among African American or blacks, even from Africa. The way we're looking at sleep in those communities is very different. So when we ask them how much sleep do you get, a lot of them would say 6 hours, 5 hours. And if you ask them, do you think you should get enough? Most of them would say no. The perception of sleep is very different based upon which ethnic group you are referring to. For instance, in Africa, which is very different from America, of course, sleeping with a lot of people in one room, one bed is considered to be normal. Whereas here, you really don't want to do that. There are many reasons why you don't want to do that. Sleep in America in 2, 3 beds, 3 people on the same bed will be very disruptive. Yet in Africa, that's just the way they feel comfortable doing that. So if you ask them, if you tell them, well, this was one of the part of the Back to Sleep campaign. You may have heard about the city, the condition where babies actually die in their sleep. If you ask African American mothers not to sleep with their babies, it's a no-no. The message enters one ears and gets out of the other. They just don't want to do that because the perception is very different. Therefore, SEED has been very prevalent in those communities. So it takes a lot of education to get also some understanding of what the cultural barriers are that prevent them from actually engaging, sleeping in different beds or what have you. But the Back to Sleep campaign, believe it or not, is having some headway. So things are changing slowly, only because the experts have recognized there are some cultural differences in terms of how people relate to sleep. So the perception of sleep need is very different. Our task now is to help people understand if you don't get enough sleep, your risk of cardiovascular disease is substantially higher. We have in some penetration not good enough, and hopefully with TASH and PZ, we should be able to do a much better job.